Hello. Uh, Good evening, namaste, and good afternoon to everyone. Welcome to this session of PAGE. And it is my pleasure to welcome our guest tonight, Dr. Murali Varma, who is a consultant histopathologist at University Hospital of Wales in Cardiff, United Kingdom. He is qualified as a postgraduate in pathology from PGI Chandigarh in 1987, and then he had US board certification as well as FRCPath, United Kingdom as well. He has his residency and fellowship in cytology, which is did in United States, and he has worked as senior house officer and registrar in Belfast, as well as consultant histopathologist in Mumbai. He is currently chairman of the British Association of Urological Pathologists, chairman working group ISUP, and member steering group of European Network of Urological Pathologists. He is a UK expert, and that I can tell you that much because I see him often, and he is kind of crucial to organizing the courses which are organized through BOP, British Association of Urological Pathologists. Some of you may have already attended some of those sessions, and he is also organizes the EQA via BOP. And if anyone has attended any of his sessions before, I think you would agree he's an excellent speaker. And I think if he has authored so many articles in uropathology, one thing I would just say, in most recent publications are worth a read. I think he's appealing to clinical doctor in us than clinical scientists in us. And I think he's trying to bring out the clinician within us, how to deliver pathology reports which make a difference to the patient. With that introduction, I will hand over to Dr. Verma, who is going to talk to us about prostate cancer grading. Over to you, Dr. Verma.
Thanks, Manish. It's a pleasure to talk to all of you. Thanks for all the kind words. Thanks to Nadeem and Santosh and the other organizers, Dr. Radhika, for this invitation. And finally, thank you to Kane Williamson for beating Afghanistan and making sure that you're not watching cricket at this time. Because I'm sure if you had a choice between watching the T20 semi-final and listening to Gleason grading, I suspect cricket would have won. But we'll talk today about prostate cancer grading and reporting, my nuances and controversies. I understand that this is primarily for trainees, and for all my trainee lectures, I invariably start with a couple of slides. It is just advice which comes from experience, some of which is bitter experience. I think, as Manish said, I think we need to always remember that we are doctors, not scientists. We are not stamp collectors reporting data for data's sake. It is data for patient management, and you always have to keep that in mind. I think it's very important for the trainees to understand that they are not students. They are apprentices. They need to take responsibility. And to the teachers, I would emphasize that we need to treat them like apprentices and not as students. And then I think in this age of webinars, I think it's very important to understand that you still have to read the papers. You will learn more from the review papers and the textbooks than you will learn by listening to me. Webinars have a purpose because it helps you focus the topic, but they are not a substitute for reading. And finally, there's a difference between learning and understanding. I think it's very important to make that distinction. I like this quote from Three Idiots. My Hindi is not good enough, so I'm going to keep the English translation, where he says the circus lion is well trained, not well educated.
But
And it's the same. I think.
can't see your slides, I think.
Oh, okay.
Manish sir, are you
Is anyone able to see my slides?
No,
sir.
no, Dr. Verma.
Okay, let me just start again. Apologies.
Sorry.
Right, let me just go back, share now. Okay. Okay, let me, yeah. You haven't missed much, is all I can say. So let's start again. I'm going to skip all that and come here. Can you see my screen now?
Yeah. Yes,
Perfect.
now we can. Yeah.
Perfect. So this is basically the quote from Three Idiots, where there's a difference between being well trained and well educated. And as trainees, it's important that you get yourself educated. And the key to getting educated is to understand the topic. And so, I'm often accused of, being philosophical and talking about pathology concepts. I think that's critical because this is not an academic exercise. Understanding concepts has very practical implications because understanding these will actually make your life easier. Now, if I compare my era as a trainee and your era, your current era, in my time, we had very little. Information. We had a few books. We had Rosai's textbook, which was our Bible. We had a small monogram from Karolinska, which was my Cytology Bible. Today, for you, it's the opposite. You are inundated with information. So where we had too little information, you have too much information, and far too many controversies. So you are living in the age of alternative facts. You've got obviously Trump, Twitter, and the various books, and the various organizations. So recently in Pathology, the expert groups have divided into two sets of sites. The Intraductal Pathologists and the Genitourinary Pathology Society publish independent guidelines and recommendations which are often conflicting. So if you just simply try to memorize the rules, you will end up entirely confused. So for example, in a radical prostatectomy where you've got 98% pattern 3 and 2% pattern 4, I mean less than 5% pattern 4, what is the Gleason score? The answer is depends. If in biopsies, everybody agrees it will be 3 plus 4 equals 7, but in a prostatectomy, ISOP would recommend using the traditional method and grading it as 3 plus 3 equals 6, while GUPS recommends even in a radical prostatectomy using the same rules like in needle biopsy and reporting it as Gleason score 3 plus 4 equals 7. So you can see that the same specimen would be interpreted differently depending on whether you've read the ISOP guidance or the GUPS guidance. So if you don't understand these, you will get totally confused. And finally, in my time, I had to remember a lot because if I didn't memorize those facts, it meant half an hour in the library trying to find the paper. You have information literally at your fingertips. So the Gleason papers, these are pretty big papers, 32 pages, 12 pages. These are large publications, but you don't have to memorize everything that's in it because you can access it on your desktop or on your smartphone. So for you, it is not about learning the facts. It is all about understanding the facts. And that is what I think I will emphasize, and I will try to take you through this. And when it comes to Gleason grading, as I said, you have no choice whatsoever. You have no option other than to understand. If you try to memorize the rules for Gleason grading, I can guarantee you will end up entirely confused. So what am I going to talk about today? I will first go through some of the basics of Gleason grading. and then we will talk about how the grading system has evolved, and finally, the new grading system for prostate cancer, the grade group system. We will then come to the nuances and controversies, and I will try to outline to you a different approach to Gleason grading. I think the current way we are doing Gleason grading is, in my opinion, entirely inappropriate, and it's not fit for purpose for current contemporary clinical practice. So let's start with basics. The grading system bears the name of Donald Gleason, who passed away quite recently in 2008. The Gleason score is a powerful prognostic parameter and a critical component of nomograms and guidelines. Now, if you look at let's start with the original Gleason system. So what are the principles? Firstly, it's a low to medium power assessment, and that still holds. You don't go into high power and try to find a small area of polyform glands and make that into pattern 4. If you do that, you will find some polyform glands, so-called polyform glands, in every single specimen. No, it's basically low to medium power assessment. Unlike the other grading systems, like in the breast, etc., cytology doesn't come into it. It's purely based on architecture, no mitotic figure counting, no, you don't take into account the nuclei, tipia, or pleomorphism, etc. It's purely based on architecture. And the strangest part of it is, I think it's only the Gleason grading system which is not by the worst. It is by the predominant plus the second predominant. So if you have this problem of Gleason pattern 4. So when you say Gleason 4, is that 4 plus? Is it got only Gleason pattern 4, or is it a 2 plus 2 equals 4? To avoid that confusion, we double it. So if you got only one pattern, so there's only Gleason pattern 3, rather than reporting it as Gleason pattern 3, we report it as 3 plus 3, primary pattern 3, secondary pattern 3, and add it up and as Gleason 6. Now, in the original Gleason grading system, the grade was included only if it was at least 5%. So if you got a tiny amount of a higher grade, which you had to really search for, you would ignore that. The tertiary pattern, when you got the primary, secondary, and a third pattern, that would not be included in the score. It's only the primary and the most prevalent and the second most prevalent patterns. And the rules were the same for all specimens, whether it's a biopsy or a TURP or a prostatectomy, you have the same rules. Now this changed. Now let's see how the Gleason system changed. To understand that, we've got to go back to the beginning. So the Gleason grading system was not the brainchild of Donald Gleason. The Gleason grading system was the brainchild of a urologist, George Mellinger. Now, George Mellinger was doing a trial on estrogen therapy for prostate cancer. And he needed that the two groups in his trial, the patients should be comparable. So he went up to Donald Gleason, his pathologist, and said, can you devise a system where these tumors would be, the grades would be similar? Donald Gleason did something very smart. Instead of using all the normal methods that are used, what has already been used in other organs, he just blindly went through all these cases and noted down the architectural pattern. He described 9 patterns, not 5, but 9 histological patterns, and he recognized that many tumors had more than one pattern, so he recorded the 2 most predominant patterns. He then passed these patterns to the statisticians, who were then given the patient's outcome by the clinicians. And the original 9 patterns were then condensed into the 5 grades that we know today. And if you look here, Gleason pattern 5, on one side we have tumor which shows no gland formation at all. That's Gleason pattern 5. On the other side, you've got something that shows a lot of gland formation, cribriform pattern with comedonecrosis. Now, which pathologist would have thought of putting these two patterns together and calling them both Gleason pattern 5 when they're clearly very different things? So this idea of putting these two patterns together was not that of a pathologist. That idea didn't come from a pathologist. It came from the statistician, because the survival data that both these patterns, the patients had a similar outcome. And it was based on the outcome that these two morphologically very different patterns were put together as Gleason pattern 5. And finally, the idea of this predominant plus second most predominant, that idea did not come from Donald Gleason. That idea came from the statisticians. John Sibela was the chief statistician. The statisticians came up with the idea that looking at the outcome, when a patient had Gleason pattern 3 and Gleason pattern 4, the outcome was not that of a pure pattern 3 or a pure pattern 4, it was intermediate. So it was the statisticians who came up with the idea of combining these two patterns. So the unique feature of Gleason grading is that it was initiated by a clinician, not a pathologist trying to find out the prognostic factors like in most other tumors. It was a bespoke system. It was created for a specific research project. So Donald Gleason was not trying to create a grading system for prostate cancer. He was trying to create a grading system for a specific research project, and the basis of this was entirely statistical. Now, I am interested in medical history, but I don't usually teach medical history but in this case, the history of Gleason grading is very relevant to what we currently do. So this is a unique, truly multidisciplinary approach where you had the urologist and the statistician with the pathologist playing a central role. So we'll just go quickly through these patterns. So here you've got Gleason pattern 1, where you had a very lobular architecture, glands which are tightly packed together, well circumscribed, non-infiltrating pattern. Now in Gleason pattern 2 was similar, but the glands were more variable in size and in spacing, unlike the tightly compact pattern 1. Gleason pattern 3, as we are all familiar with, this is the traditionally the most common pattern, where the glands are separate and separated by stroma. They are angulated, they are discrete glands, but they are not tightly packed. And then we have pattern 4, patterns of pattern 4. You have the glandular fusion pattern, and then what was described as a hypernephroid pattern by Donald Gleason. We no longer recognize the hypernephroid pattern. I think most of us now would simply call that as pattern 5, because if there is no gland formation. Now, I would like to clarify one thing about gland fusion. So when we think about glandular fusion, there is a tendency to think of it as fusion, that we've got two separate glands which have now come together and fused. That is not what is happening with glandular fusion. This is not true fusion. What it is you've got increasing architectural complexity resulting in apparent fusion. So when you get a convoluted growth pattern with budding, now it's similar to an atypical endometrial hyperplasia where you get back-to-back glands. So if you've got glands which are all parallel to one another and you cut them, they will look like this, and that's Gleason pattern 3. But when these glands become more complex with budding, then when you get a cross section through it, they appear fused. So this is not true fusion. This is purely an artifact of plane of section. So you get increasing complexity from pattern 3 to pattern 4. So this is a morphological continuum. And then finally, you got Gleason pattern 5, which has two different patterns, either no gland formation at all or comedonecrosis. Now, this didn't stop here. Gleason grading has evolved. So that was the original Gleason what Donald Gleason published. But then it has changed dramatically. Now, incidentally, the first change in the Gleason grading system was way back in 1977 by Donald Gleason himself. So the original Gleason score included the clinical stage. So it was a predominant pattern plus the second most predominant pattern plus the clinical stage. So the scores ranged from 3 to 15. The clinical stage was dropped in 1977. So this is just a quirk. This has no clinical relevance. But what was important is what happened after that. The Gleason grading system was adopted in 2004 as the only grading system for prostate cancer. And since then, it has undergone multiple changes. So there were changes in 2005, in 2014, and now in 2019, where we had separate changes published by ISOP and GUPS. So two different set of experts have changed the Gleason grading system differently. So the question that we have to understand first is why change? So why did we need to change the grading system? There's no other grading system that changes like this. So why did we change it? And the reason for that is that the classical Gleason system is essentially obsolete because of the history. So if you look at the original Gleason grading system, this was very different patients from what we are dealing with today, especially in the West. This was in the pre-PSA era. 86% of the patients in the Gleason study had advanced prostate cancer. Today, we apply the grading system predominantly in the West to patients with early prostate cancer. There were different specimens. So these were TURPs, open prostatectomies, and thick needle biopsies. There were no 18-gauge needle biopsies that we currently deal with. And finally, the lesions that he was reporting is very different. This was pre-immunohistochemistry. So a lot of what Gleason was calling Gleason pattern 1 prostate cancer, we know that if you do immunohistochemistry, they have basal cells. And today we won't call that cancer at all. We would call that adenosis or atypical adenomatous hyperplasia. So Gleason pattern 1 essentially doesn't exist. We believe that most, if not all of it, was benign. And then you got Gleason pattern 5 with comedonecrosis. If you go back to your Gleason pattern 5 with comedonecrosis and do basal markers, most of this, not all, but the majority of them would show a well-defined basal layer. So what Gleason was calling Gleason pattern 5, comedonecrosis pattern 5, was actually intraductal carcinoma. So we needed to change. So clearly, the original Gleason grading is not fit for contemporary practice. So what changes were made? Now, the main changes were made in 2005 and 2014. Now, of these two, the major changes were in 2005, and in 2014, it was largely minor tweaking. In 2005, the definition of patterns was changed. The way we create the scores in biopsies was changed. The way we report the scores in biopsies was changed. In 2014, it was just tying up some loose ends from 2005. The percentage pattern 4, reporting of percentage pattern 4 was recommended. And the main change was the novel grade group system, which was proposed in 2014. So what were the changes here? So if you look at the definition of patterns, in 2005, Gleason pattern 1 was essentially abolished, and Gleason pattern 2 for all practical purposes was abolished. So Gleason pattern 1 doesn't exist, and for practical purposes, we never report Gleason pattern 2 in biopsies, and we almost never report Gleason pattern 2 in any specimen. Now, why is that? Because if you look at Gleason pattern 2, we rarely see it in radical prostatectomies as small anterior transition zone tumors. In QRPs, they are uncommon, and in needle biopsies, these tumors are not sampled by needle biopsies. They're anterior tumors, and you get the tip of the iceberg. So if you get something like this in a biopsy that looks like a Gleason pattern 2, well circumscribed borders, they are not compactly packed like Gleason pattern 1. So So this is the sort of one that could be a Gleason pattern 2, but that is likely to be a tip of the iceberg. So you've got an infiltrating tumor like that, and when you slice it in this plane, it appears to be circumscribed. You cannot see the whole margin, and so it appears to have a circumscribed edge. And so that's why we don't report Gleason pattern 2 at all. The other thing that was done in 2005 was a definition of patterns changed. So we had these poorly formed glands where you're not seeing a glandular lumen. These were called as Gleason pattern 4. So this was not something that was recognized by Donald Gleason. This was something that was introduced in 2005. And then cribriform cancer. In the Gleason grading system, the original system, cribriform could be seen in pattern 3, pattern 4, or pattern 5. In 2005, it was said that almost all cribriform glands would be considered pattern 4 or pattern 5 if they had necrosis, with the rare exception of small round cribriform glands which would be pattern 3. In 2014, it was simplified by saying that all cribriform glands, irrespective of size and shape, would be considered pattern 4. So if you get something like this, a small gland, well circumscribed with a cribriform architecture, rounded outlines, this is the sort of thing that in 2005 system would have been called pattern 3, but now even this would be considered as pattern 4. And then you had glomerations where you got these budding of cells. So this is this sort of intraluminal proliferation, which look like glomeruli, that's considered as pattern 4. Grading variants, we do not grade small cell carcinoma, and ductal carcinoma is generally considered would be high grade. So it would be pattern 4, or with necrosis, pattern 5. An exception to this was a so-called pin-like ductal carcinoma. So when you get something that looks like high-grade pin, but the nuclei are oval, pseudostratified. So they have the ductal cytology with acinar type architecture. That was what Jonathan Epstein described as pin-like ductal carcinoma. These would not be graded as 4. So this would be considered as Gleason pattern 3 because it doesn't have a cribriform architecture. These are still separate glands, so they are not pattern 4. So in the new WHO, which will be coming out next year in WHO 2022, it will be, we will be getting rid of the name ductal. So we won't be calling this pin-like ductal carcinoma anymore. We'll simply call it pin-like carcinoma and recommend that this would be generally Gleason pattern 3 unless you got fusion or cribriform architecture. And then we had the reporting of the Gleason scores. So in the original Gleason grading system, the biopsy score would be would have been the predominant plus the second most prevalent, and the same rule for all specimens. In 2005, we changed that the Gleason score in the biopsy would be the predominant plus the worst. And any higher grade, even if it is less than 5% or it is tertiary, would be included in the Gleason score. So why do this? So the reason for this is the sampling error of the needle biopsy. So if I've got a 3+3 with a little bit of pattern 5 in the biopsy, there could be a lot of pattern 5 in the patient because of the sampling error of the biopsy technique. So if you only report it as 3+3, that could be misleading, which is why in a biopsy, we now report it as the predominant pattern plus the second most predominant pattern, or the worst, the predominant pattern plus the worst pattern. So even if it is less than 5%, even if it is the tertiary pattern. And the other thing that was suggested in Gleason, what was recommended in ISUP 2005, was to report a separate Gleason score for each positive biopsy. So if you had multiple cores, multiple positive cores, 3+4, 3+4, 3+4, 3+3, and 4+4. So ISUP 2005 recommended separate Gleason scores, and the clinicians would then use the worst Gleason score. So in the classical system, this case would have been reported as 3+4 equals 7. In ISUP 2005, it would be 4+4 equals 8. We'll come back to this because there are issues with this. Now, what is the effect of all these changes? Marked grade inflation. In the past, the most common grade was Gleason 6. Today, the most common grade is become Gleason 7. And in this study, what they showed was after using the ISUP 2005 system, 35% of the cases were upscored. And the vast majority of this upscoring, the 90% of this upscoring, was due to reporting separate grades for separate specimens and using the highest score for management. And then finally, we came up with the new grading system for prostate cancer. This, as you can see, got a lot of coverage in scientific literature, as well as in the lay literature and financial review, etc. And everywhere, the key word is the new grading system. Now, what I'll try and explain to you is that there is no new grading system for prostate cancer. What ISUP 2014 came up with, and this was then adopted in WHO 2016, was the grade group system. It was only a different way of grouping the grades or scores. And Gleason scores have always been grouped. Traditionally, there were different ways of grouping it. It was 2 to 4, 5 to 7, 8 to 10, 2 to 6, 7, 8 to 10, so on and so forth. Clinicians have always grouped the scores. That's nothing new. So it is just that ISUP 2014 grouped the scores differently. So where you had a separation between 3 plus 4 and 4 plus 3, and a separation between 8 and 9 and 10. So that's different, but it's not a new grading system. So what they had essentially, so if you, it does not give you any additional information. So if I just report the Gleason score, the clinician or the patient can derive the grade group. So this can be derived from the Gleason scores. But it is clinically useful. It's clinically useful if patients read reports. So if you have a situation where the patients are directly reading the histopathology reports and trying to interpret it with the help of the internet, then it becomes useful. And the reason for that is Gleason grade 3 plus 3 equals 6. There is a communication gap here between us and the patients, which is as wide as the Grand Canyon. Gleason scores range from 2 to 10. So if you're told that there's a grading system where the minimum is 2, the maximum is 10, and your Gleason grade is 6, naturally the patient will assume that he's at intermediate risk, that this is somewhere in the middle. But we know that the minimum grade that we would report in a biopsy is Gleason 6. So that's why this can be misleading for the clinicians, for the patients, and I think it was a very good idea. So the grade group system is not a new grading system, but it has a novel feature which was first proposed by Jonathan Epstein, which I totally endorse, which is a very good idea to have the numbers 1, 2, 3, 4, 5 for these groups. Now, what's the advantage of that? Because now when we report it, you got Gleason's grade 3 plus 3 equals 6, grade group 1. And it's clear to the patient that he is at the lowest risk level. So this was about communication. If your patients do not read your reports, then the grade group system really doesn't matter. If it is a clinician who's interpreting the report for the patient, then if you write 3 plus 3 equals 6, the clinician would translate that to explain to the patient that you are at the lowest risk group. So the point I'm trying to make here is don't worry too much about the grade group system. It's not a new system. There's nothing new for you to learn because of the grade group system. So now we will move on to the nuances and controversies and a different approach. Now let me start by making a confession. The biggest controversy in Gleason grading is intraductal carcinoma of the prostate, whether to grade it or not to grade. As Shakespeare would have put it, that is the question. So if you have got 3 plus 3 equals 6 here. So now what I've got here is the invasive component is all Gleason pattern 3. As you can see, is negative for basal markers. And you got these large cribriform glands that look like cribriform pattern 4. But when you do basal markers, they have got a well-defined basal layer. That's intraductal carcinoma. So how do you grade this? Depends whether you follow the ISUP guidance or you follow the GUPS guidance. ISUP would include this into the grade and would report that as 4 plus 3 equals 7. So even though they have got basal cells, even though this is an intraductal, it's included into the Gleason score. While GUPS would report it separately as 3 plus 3 with an intraductal component, and then write a comment saying that intraductal has a bad prognosis. Now, I'm not going to go through in the details of all this today, because I think it's simply too complicated. If I try to do that, we'll be there for another hour. So I will leave that for another day, but I'll just leave you with a message that ISUP and GUPS are really not that different. It's only a different language. They're both saying exactly the same thing, that this patient has got bad prognostic parameter, whether you call that cribriform invasive or you call it cribriform cancer and you call it Gleason pattern, whether you call it Gleason pattern 4 or you put a separate comment and call it IDCP, the message is identical. We'll talk about this another time. So for those of you who are interested, there is this paper, which was basically a head-to-head debate with which I had with Jonathan Epstein, where each of us put forth our arguments why we think it should be graded or not graded. And there is this review paper on intraductal carcinoma where I have gone in more details about my view on intraductal carcinoma. So today I'm not going to talk about intraductal carcinoma. I'm going to talk about the more common issues like the borderline Gleason scores. What do you do with that case where you're not sure whether to call it pattern 3 or pattern 4? Now, I'm going to recommend a different approach. So I will try to explain to you why we need a different approach. I will outline a different approach to Gleason grading and then use a couple of examples to illustrate how using this different approach to Gleason grading would make your life easier and the patient's life better, or the patient management certainly better. So I think if I'm going to tell you to change the way you're doing, then I think the onus or the responsibility is mine to convince you that you need to change. So why do we need to change? So for that, let's start from the very beginning. Why Gleason? The Gleason grading system is not the only grading system out there. In 1978, the American Cancer Society arranged workshops where they compared Gleason, Mostoffy, Gator, and the Mayo systems and recommended Gleason because it was definable, simple, reproducible, and had compelling clinical evidence. Now, to me, the word that stands out is simple, because whatever else the Gleason grading system is today, it is not simple. You have textbooks, they're very good books, but whole textbooks on Gleason grading. Are you aware of any textbooks on endometrial cancer grading or breast cancer grading? No. But the fact that you can have whole books on Gleason grading suggests to me that the grading system is far too complicated for general use. And then we've got this, where you get two societies publishing conflicting guidance. So I think the Gleason grading system is very complicated, and in my opinion, it's, here's examples where the GUPS and ISUP recommend grading the same case very differently. And in my opinion, it's overcomplicated. It does not have to be so complicated. And if I can get this across to you, I'll explain to you how we can find a way through this minefield and actually make it quite simple. So as the Godfather would say, how did things get so far? That we took a system, we adopted it because it was simple and made it so complicated that none of us can do it. And more important, how do we sort this out? And to me, my answer is a different approach. I'm sure others will have other answers. And what is this different approach? Is using your medical hat on. Focus a little less on the specimen and a lot more on the patient. So the focus should be on the clinical utility of the grade and not recording the grade, but communicating the grade, the message behind the grade. Now, again, I don't have time today to go through all the details. For those of you who are interested, here is a review paper, which it is an open access paper. So you can go through that. That has all the details. Today, I'm just going to show you a couple of examples. So when it comes to clinical utility, let's look at radical prostatectomy Gleason score. How do you treat patients after prostatectomy? There are two options. The first is, like in any other organ, adjuvant therapy, which is basically a post-surgery, there's adverse pathology. Those patients are treated with chemotherapy or radiotherapy up front in other organs, and the same in prostate, which will be hormones and radiotherapy. But the difference in prostate compared to all other organs is PSA. So we've got once you've done a prostatectomy, PSA is an excellent tool for monitoring these patients. So you could simply not treat the patient, follow up the PSA, and treat them only if the PSA rises. That is what is called salvage therapy. PSA identifies early recurrence and metastasis. Adjuvant therapy, radiotherapy, has very significant morbidity, especially to the bladder and the bowel. So in many countries, PSA monitoring is the norm. Like in the UK, the standard is PSA monitoring. So irrespective of what you report in your prostatectomy, that's all prognostic information. But for management, they simply follow the PSA. And here is the American guidelines. So here, if you read the NCCN guidelines, they talk about adjuvant radiation with or without hormones can be given to men with adverse pathologic features like positive margin, seminal vesicle invasion, and extracapsular extension. But they state observation after prostatectomy is also appropriate. And the important point to note here is even in the American guidelines, they do not talk about the Gleason score. They talk about the tumor stage and margin status. So the Gleason score in a radical prostatectomy actually has very limited clinical utility. So then why do we complicate things like this? Why do we talk about different guidance when we say that we should search for 2% pattern 4 to change the grade when it's not going to change the management? And my concern with this is that when we do that, the practicing pathologist gets confused. You will get even more upgrading because now you are including the cases with tiny bits of pattern 4. So you get more Gleason 7s, and pathologists will start worrying and searching and wasting time searching for a tiny bit of pattern 4 when it's essentially the same message. 3+3 with less than 5% pattern 4, whether you call it Gleason 6 or you call it Gleason 7, it's the identical message and it has no clinical management implications whatsoever. Then why? So again, so essentially the point I'm trying to make here, in a radical prostatectomy, don't worry too much about the Gleason score. You want to get, it is prognostically important. The nuances are not that important because it has no management implication. Now, when it comes to needle biopsies, now this is obviously where the big management implications of Gleason grading are. And here, the key is communication. Again, I don't have time to go through all the details. And here's a review paper in Diagnostic Histopathology where we talked about communicating prostate biopsy results, not just the Gleason score, but tumor extent and everything else. Again, I would recommend this for more details. But when we look at the borderline Gleason scores, now whether I call this Gleason 6 or Gleason 7, that could change the patient's life. We are talking about a prostatectomy or no prostatectomy, a risk of incontinence and wearing diapers for life, which is a major change to his life. But we know that this is extremely subjective. There is significant inter and intra-observer variation, even among experts. I mean, I regularly see cases that on one day I would call it Gleason 6. You show me the same case on another day, I might well call it Gleason 7. So what do we try to do? So the traditional approach to this is to focus on precision. So we have detailed criteria, reproducibility studies, a lot of lectures showing you pictures, trying to get that exact cutoff between Gleason pattern 3 and Gleason pattern 4. Now, I will asked two questions. Precise Gleason grading in biopsies, is it possible and is it necessary? And in my opinion, the answer to both these questions is a resounding no. Why do we grade tumor in biopsies? Nobody is interested what the grade of the tumor in that tiny sliver, that tiny bit of tissue, the needle biopsy. The grade of the biopsy is irrelevant. What the clinician and the patient is interested is, what is the grade of the tumor that the patient has? And the biopsy tumor, how good is it at predicting what the patient really has and which will predict his outcome? Not very good because of sampling error. So here you got two large studies comparing the Gleason score in the biopsy with the Gleason score in the prostatectomy. The one is from Johns Hopkins, the other from Karolinska. So these are all experts. So these are people who definitely know what they're doing. So let's see what their results were. Biopsy 4 + 4 = 8. What did the radical prostatectomy show? In half the cases, the radical prostatectomy downgraded. Now we know there's going to be some degree of sampling error and some change. Oh, well, that's reasonable. But it's not just that. In about 20% of the cases, it was primary pattern 3. So what was 4 + 4 on the biopsy turned out to be either 3 + 3. So obviously there was very little pattern 4 which was not found in the radical, or 3 + 4. Now that is a big change. And this is not just these studies. There are several other studies showing that, while this one says most glycinate biopsies are downgraded, so should it be 4 + 4 = 7, and so on. And it's not just with these. So if you look at 3 + 4 = 7, about 20% would be upgraded on the prostatectomy. Biopsy 4 + 3 = 7, about 40% would be downgraded on the prostatectomy. So the biopsy is only a rough estimate of the true Gleason score. So perfect precision is simply not possible. However wonderful the pathologist might be, you cannot guess what you cannot see. But then, is it necessary? Now, the Gleason score, all grades, whether it's it's not just whether it's breast, lung, etc. They're all morphological continuums with subjective arbitrary cutoffs. But it's also a biological continuum with a progressive increase in risk of adverse outcome, whether it is EPE.
Yeah,
So your PowerPoint
your presentation again.
Okay, what are you seeing?
Nothing. Your presentation is gone again.
Oh, okay. I'm not sure why. Okay, let me just switch off. Okay. You're not seeing anything at all, is it?
We are looking at your camera, basically. We are looking at you.
Oh, okay. Well, is that any better? Okay, let me start again. I think, okay, for some reason, I think I've lost the, okay. Select window. Yeah, I think if you're not seeing my screen, shout, okay, because I'm afraid this is part of the problem with these virtual lectures. You never know what you're seeing. Okay, let's try again. Can you see my screen now?
Yeah, it's
okay.
visible now, yeah.
Right, so I think you may miss some of the slides, but it's not the point I was making there, that because of the sampling error of the biopsy score is only a very rough guesstimate of the true tumor score or the tumor grade. Now the next question is precise grading necessary? So the Gleason score is a morphological continuum with arbitrary cutoffs, but it's also a biological continuum with increasing risk of extraprostatic extension, lymph node mets, death, whatever outcome you want to take. So at what risk, what minimum risk of EPE would you call it Gleason score 7? 2%, 3%, 4%? Nobody knows. And this is not peculiar to Gleason grading. These arbitrary cutoffs is what we use for like in PSA. So when the clinicians put patients into low risk, intermediate, high risk using PSA cutoffs of 10 and 20, why 10 and 20? Why not 7 and 17? It's purely for convenience. So these cutoffs are entirely arbitrary to distinguish between, to cut off between low, intermediate, and high, or Gleason 6, Gleason 7, Gleason 8. So these are arbitrary cutoffs. Now, however arbitrary these cutoffs may be, they can drastically change patient management. So how to report a borderline case? So when you got a case which is bordering between Gleason 6 and Gleason 7, how do I deal with that? So the point to understand is that a good Gleason 7 behaves no different from a bad Gleason 6. So if you got a tumor which is at this end of Gleason 6, at the bad end of Gleason 6, it doesn't behave any differently from a tumor at the good end of Gleason 7 because it is a biological continuum. So what that means is a tumor at the bad end of Gleason 6 can be treated like Gleason 7, and a tumor at the good end of Gleason 7, it's entirely reasonable to treat it as a Gleason 6. So as pathologists, we are worrying too much about getting it exactly right. Now, if I take hypertension, if I've got a patient with a systolic of 119, that's a normal blood pressure, no treatment. Blood pressure 159, bad stage 1, the patient needs treatment. But when I have somebody in between, a 139 and a 140, which is a purely arbitrary cutoff of 140 to say the patient is hypertensive, whether to treat or not to treat will depend on other risk factors. So a patient with 139 would be treated if he has other risk factors. A patient with 140 would not be treated if he doesn't have other risk factors. And it's exactly the same with Gleason grading. So when I've got a patient who is borderline between 6 and 7, it would be entirely reasonable to treat or not to treat based on other risk factors and patient preference. So may want to play safe and have a prostatectomy. On the other hand, a patient with a good Gleason 7 may opt for surveillance. Perfect precision is not possible, and it's not necessary provided you communicate it properly. So the problem we have, the reason we struggle with Gleason grading is the communication gap. Surgery. So when you look at radiology, the surgeon looks at the radiology report in conjunction with the radiology images. So the finer nuances here, he can see it for himself. But when it comes to pathology, he is entirely dependent on our written words. So grade is a morphological and biological continuum with arbitrary cutoffs, and the issue is suboptimal communication. So this distinction, the time that we spend worrying whether it is Gleason 6 or Gleason 7, you can report that in seconds if you focus on communication.
Dr. Varma, we lost it again, sorry.
Oh, God. I'm not sure what's happening there. Sorry, this is annoying, but let me go back. Can you see my screen?
Yes, it is uploading now. Yeah. That's
okay.
it.
Right. So if we compare it with renal cell carcinoma staging, which again is a morphological and biological continuum with arbitrary cutoffs. We use a cutoff of 7 centimeter to distinguish between PT1 and PT2. But when is the last time you reported a renal cancer as just PT1 or PT2? You wouldn't. You report it. You give the size in millimeter and the stage. So it is obvious to the clinician whether this PT1 tumor, whether it's a 69 millimeter PT1 or the PT2 tumor is a 71 millimeter PT2, which is much the same as a 69 millimeter PT1, or 152 millimeter PT2, which is an entirely different, has a different prognosis. So that is communicated to the clinician. But when it comes to grade, we have this continuous variable. So it's a continuum, but we report it as if it's a discrete variable. So when we report something as Gleason score 7, at this end, it's not really different from Gleason 6. At the other end, it's very different. Now, this is not just about Gleason grading. In fact, the situation is even worse with bladder grading. In my opinion, the the WHO 2004 is a very dangerous change, where we now report low grade and high grade. Now, when you report that as high grade urothelial carcinoma, and that's all the report says, how is the urologist supposed to know whether this is a tumor which on another day you would have called it low grade, or some other expert would have called it low grade? So this is at the low end of high grade, or this is the worst high grade tumor you have ever seen. The report just says urothelial carcinoma high grade. The surgeon doesn't look at the slides, so he doesn't know. And that's why I think we need to focus on communication. The report may not indicate where an individual case lies within the grade spectrum. So our reports have to bridge this communication gap. They don't look at our images. They don't look at the histology. So in practice with Gleason score 7, obviously I don't report it as Gleason score 7. I would report it as either 3+4, that's grade group 2, or 4+3, depending on whether it's predominantly pattern 3 or predominantly pattern 4. But again, this cutoff is purely arbitrary. This 50%, what's magic about 50%? That was entirely for convenience. It's not that a 49% tumor will behave differently from a 61% tumor. So it's all for communication. But when I report it as 3+4 equals 7, how is the clinician and the patient supposed to know whether this is at the good end of 3+4 equals 7, which is not really that different from Gleason 6, or at the bad end of 3+4, where it's different? So which is why we report the percentage pattern 4. So when we report the percentage pattern 4, the idea is saying that if there is very little pattern 4, this patient may be suitable for surveillance. On the other hand, a patient with about 50% pattern 4, that's 3+4, a bad end, this patient may not be suitable for surveillance. So it's all about communication rather than precision. Now there's an issue with percentage pattern 4. What are we comparing? So when I say that the percentage of pattern 4, is it the tumor area, the area of the prostate, or the number of cells? Nobody has discussed this, and nobody knows. To be honest, we are all doing it differently. So if I've got this tumor in a radical prostatectomy, you can see that some areas are microcystic, other areas are cribriform, and then you got areas of the usual pattern 3. So this area occupies more prostate area because it includes a lot of stroma. In this one, there's a lot of cells in the same amount of area because there's very little stroma. While in this microcystic one, there are few cells in a large area. So you can see that what we are comparing, so don't fuss too much about percentage pattern 4. I have checked this with the various international experts, and everybody agrees we really don't know what we are comparing. So this is not very scientific. So the idea of reporting percentage pattern 4 is not to decide how much pattern 3 and how much pattern 4 and what is the precise, accurate percentage pattern 4. No, that's not what it is. Now, again, I'm showing you an example in a needle biopsy. In this part, it's pattern 3. In this part, it's pattern 4. What is the Gleason score? If you take the number, if you take the area, then there is more pattern 3 than pattern 4. So it will be 3+4 equals 7. If you take number of cells, there are almost certainly more cells in this smaller area. So it will be 4+3 equals 7. So it's not about the precise percentage. You need to focus on the message. And the message is, when I say less than 10%, so in practice, how do I report percentage pattern 4? If I've got a case where I'm not sure, whether to call this Gleason 6 or Gleason 7, it's a borderline case. I've got a small area. Is it fusion, not fusion? Then I report it as less than 10% pattern 4. If I've got a case where I'm struggling to decide whether it is 3+4 or 4+3, there are almost equal amounts of pattern 3 and pattern 4. And I don't waste time trying to decide whether it's pattern 3 or whether it's predominantly 3 or 4. If I'm going to report it as 3+4 equals 7, then I report it as 3+4 equals 7, 50% pattern 4, or I report it as 4+3 equals 7, 60% pattern 4, which is exactly the same message. So once you focus on the message rather than the precise amount of pattern 3 and pattern 4, life becomes a lot simpler, and the patient's management also gets a lot better because you have conveyed what the message that you want to give. So this is, you're improving it by, and this is not just about pattern 3 versus pattern 4. It is just as important in pattern 4 versus pattern 5. We know there is significant issues with reproducibility when it comes to comparing pattern 3 and pattern 4. Pattern 4 and pattern 5 when you got single cells and cords. So when you got something like this is Rajal's inter-observer study. So are these polyform glands, or is this Gleason pattern 5? It depends which expert you ask. 64% of these international experts called it pattern 4, but 36% thought it was pattern 5. So you can see that there was no consensus even among experts. So in this sort of case, the patient's management should not be based just on a toss of a coin, whether you happen to call it pattern 4 or pattern 5. So in these, it is important for you to say that. So if I've got this, so I would report this as 4, as 4 plus 3 equals 7 with foci bordering on pattern 5. Now, if you want to call this 4 plus 5 equals 9, that's fine, provided you say that there are foci just amounting to pattern 5. Then you have conveyed that message. Why is this message important? Because if I report it simply as 3 plus 4 equals 7, without saying that it is bordering on pattern 5, this patient may opt for surveillance, and that might not be the right treatment for the patient. Repeat biopsies to make sure that he really doesn't have a pattern 5 may be what he needs. You need to convey that message. If you're hiding that from the clinician and the patient, then you're not doing your job. So the key is communication, and if you communicate properly, then precision becomes less important. But that is not enough. Now again, so this is again, I've gone through only the outline of what I'm telling you just now about the importance of communication. If you can go through this editorial where we discuss the issues in more detail. But that's not enough. You also need it to be interpreted properly. What I mean is this: Gleason pattern 4 plus 3, 80% pattern 4. Bad news, patient should not get surveillance. Yes, that's true if it is a 20 millimeter tumor. But if you got 4 plus 3, 80% pattern 4 in a 2 millimeter tumor, does that preclude surveillance? Probably not. The patient needs a repeat biopsy because he might actually be having very little pattern 4. So 80% of 2 millimeter is not the same as 80% of 20 millimeter tumor. So there is a denominator you've got to consider and needs to be judged. Okay, I'm going to skip this bit for time purposes. I think we'll leave all this and go to the bottom. So I'm going to stop here now, and we will, Gleason score is critical for patient management, so it is important to get it right. Gleason score is a morphological and biological continuum, but in borderline cases, so I'm not telling you that Gleason score doesn't matter, and you don't need to, just toss a coin and put any Gleason. That's not what I'm saying. You make every effort to get it right, but in those truly borderline cases, the ones that are where they are morphologically borderline between pattern 3 and pattern 4, or pattern 4 and pattern 5, the key is communication, to tell the clinician and to tell the patient that this is a borderline one and he can opt for either management option. And finally, it's a plea to the experts to, well, we've got one of the editors of WHO 2022. I think we need to work towards consensus. The current state of play, where we've got ISUP and GUPS publishing conflicting recommendations, is simply not tenable. We are confusing pathologists, we are confusing clinicians, and we are confusing patients because they get different opinions from different people and nobody knows. And the risk with this is that we risk undermining our professional credibility, and eventually there is a danger that we will all lose because the clinicians will say that, oh, well, these guys don't know what they're doing. And finally, I very strongly believe, not just about Gleason grading, but in everything in pathology practice, keep it simple. The default should be simple, and that doesn't mean that you oversimplify things. If things have to be complicated, then you complicate it. But complicated reporting rules should be the last resort when there is proven clinical utility and not the current practice where we seem to be complicating things for complication's sake. I'll leave you with some references. So these are the standard, the ISOP and GUPS references. And then finally, for my views, so these are my own references where I have outlined my views in greater detail. Thank you for your attention.
Thank you very much.
I will now stop sharing.
Thank you very much, Dr. Varma. That was a brilliant talk, and how you have taken us through the Gleason grading, and I think I'm really like the idea of us being more clinical doctors rather than clinical scientists. I think that's an important message for all of us in this talk. I don't see any questions in the chat box at the moment. If I may ask you something.
Obviously, I've either made it extremely clear or I made it so complex that nobody knows what the hell I'm talking about. Go ahead.
We'll see. I'm sure there will be a couple may come up soon. In that, from the practical aspects, Dr. Varma, I think cribriform is something we can easily identify. I think most pathologists would recognize cribriform patterns quite decently. The question is about poorly formed glands, and gland fusion is always a tricky bit, I think.
Correct, Manish. So I agree with you that poorly formed glands, trying to decide whether it is tangential sectioning. So if you look at the definition of fusion and the definition of poorly formed glands, the definition is when you can confidently exclude the possibility of tangential sectioning. That's entirely subjective. So, by definition, right? So you have to. There will always be a degree of subjectivity, however you do it. The other one, Manish, the cribriform one is actually interesting. I was recently involved in the expert group consensus, kind of a consensus meeting, and we had a set of it, a Zoom based, about definition of cribriform. And there's huge variation among experts. So yes, you got the obvious large cribriform areas, rounded glands with punched out spaces. Everybody agrees that's cribriform. But at the other end, between fusion versus cribriform, even among experts, there's huge inter-observer variation. So this is an issue. So and this again is an issue in pathology in general. We often treat by name. So just because we give something a name, that doesn't mean it's going to behave like that, because often that name is extremely heterogeneous. So you got, as I said, like high-grade urothelial carcinoma, the tumor at the low end of the high grade and the tumor at the high end of the high grade will actually behave quite differently. Yeah, Radhika?
Yeah, I just wanted your thoughts. The more this is a more general philosophical question, the more we keep harping about inter-observer variability, and then in these days we have the software guys just at our necks, and tomorrow they'll say, okay, then let AI and digital whatever take over, because you guys always have so much of variation. And you also kept on harping on the fact that on the intra as well as the inter-observer variability, and I suppose prostate is an extreme case of this kind of variability, but it of course exists in all other systems. I'm really glad I'm not a uropathologist at the end of this talk. I think where do you think?
Welcome to my world, Radhika. Yeah, but Radhika, let me just make. I think it's an important point you make. This question about credibility, that with but I think I would argue exactly the other way around. That essentially what we've got to do is, this is a continuum. That we should not be ashamed of the inter-observer. The blood pressure readings. That we say above 140, the patient is hypertensive. Below 140, the patient is not hypertensive. If you get two people doing the reading twice, in those borderline cases, one will be 139 and one will be 141. AI is not going to solve that problem. The AI will have the borderline cases in a morphological continuum. You will have borderline cases, whether you do AI or you do whatever you want. These cutoffs are arbitrary. So it's all about, so this is my point. If we behave like scientists and say, pretend as if we can be accurate and precise, then we have a problem. But if we behave like doctors and say, yes, we know it is a continuum, whether the blood pressure is 126, 128, 132, 141, that is a continuum. But we will try and tell you approximately where it is, and we communicate that properly, then your problem is solved. So once I communicate that this blood pressure is around 140, it's just below 140 or just above 140, then there is no problem anymore. And I think that is the same for in everything in medicine. If provided we communicate, and as I repeat, because the clinicians do not look at our histology, they are entirely dependent on our written words. And that is why our communication of the written report has to be so good. I think somebody had a question about what do I mean by bad end of Gleason pattern 3. Now, I tried to show you that picture between pattern 3 and pattern 4, where the glands become increasingly complex. The proliferation becomes increasingly complex, and they appear to be fused or poorly formed. Now, at what degree of complexity does Gleason pattern 3 become pattern 4? So when it becomes very complex, all of us agree that this is pattern 4. But then you will get other ones where it is complex, but it's not complex enough to be pattern 4, where some people would say this is enough for pattern 4. Others would say that this is not enough. I would still call this pattern 3. So in those cases, I would put a sentence in there. So where I would write Gleason score 3 plus 3 equals 6 with foci which are bordering onto pattern 4. Now the advantage of this is twofold. For the I know a lot of pathologists in my part of the world who basically are very worried that I will change the Gleason score in the MDT. So they are not trying to report the Gleason score. They are trying to think, what will Murali call this when he reviews it for the MDT? Now that is silly. So in these cases, if they report it as 3 plus 3 bordering onto pattern 4, and if somebody else changes that to 3 plus 4 equals 7 on review, it is obvious to the clinician and the patient that this was a borderline case to start with. And it's no big deal that somebody is gone to the other side of the border. And same way, when I review cases for the multidisciplinary team meeting, when I'm reviewing somebody else's work for patient management, I do not try to grade the case. What I am looking at is the reported grade acceptable? So if I've got a case where if it had been my case, I would have reported it as 3 plus 4 equals 7. But I know this is a borderline case. I know that you show it to some other expert, some experts would call it Gleason 6. Some experts like me would call it Gleason 7. Now, in the MDT, I would not change the outside pathologist grade. So the outside pathologist called it 6. I would leave it as 6, but I would say in the MDT that this is bordering on to pattern 4. This is bordering on to 7, because 3 plus 3 bordering on to 7 is exactly the same as 3 plus 4 just amounting to 7. So you can, without losing the credibility of the reporting pathologist, without upsetting the reporting pathologist, without causing problems for both the pathologist, the clinician, and the patient, creating confusion for everybody, you can avoid that with communication. Right? You can give exactly the same message without changing the Gleason score. Is it clear? I hope it is.
Yeah.
Thanks.
Second, I'll ask you another provocative question.
Yeah,
you did mention, of course, that cytology is not important, at least in the prostate. To some extent, architecture, I mean, biologically, of course, architecture should go hand in hand with cytology. I mean, the as it gets worse and becomes solid, obviously, the nuclear changes also will be there. Why is it that somehow cytology never got importance in prostate grading?
Correct. That's a very, very good question, right? So, two answers to this. The first answer was there were several grading systems like the Mostofi system, which was the original WHO system for grading prostate cancer, which included the cytology. The Gleason grading system was adopted because it was simple. So it was not that there were no grading system for prostate cancer that included cytologic evaluation. We chose not to use those and to use a more simple system, which is based entirely on architecture. The other problem in the prostate is that prostate cancer usually is not very pleomorphic. Even Gleason pattern 5 prostate cancer generally shows very little pleomorphism. If you're seeing, you may get very atypical nuclei with very big nucleoli, but each of them look the same. All of them are very large nuclei, big nucleoli, but each nucleus looks identical to its neighbor. If you see significant nuclear pleomorphism in a 5+5 prostate cancer, what should you do? Think about the possibility of urothelial carcinoma. So if you're seeing significant nuclear pleomorphism or a desmoplastic reaction, it's not that you can never get those in prostate cancer, but always consider the possibility of TCC and consider, I'm not saying that you have to do the immunohistochemistry, but unless you can confidently exclude the possibility of TCC, do the immuno, because the management is so different.
I have two questions,
Yeah.
Dr. Varma.
Yeah.
One, I'll take them together. I think one question is, do we grade ductal carcinoma? And the other one is, how often we get combined intraductal carcinoma and acinar adenocarcinoma?
Okay, I'll deal with the first one first. Let me just again make one clarification. I didn't have the time to go through intraductal, which is again, I think we have markedly overcomplicated and confused everybody with intraductal. And in my opinion, that wasn't really necessary, but that's for another day. We got to make very sure when we talk about the word ductal in ductal carcinoma and ductal in intraductal carcinoma, those two things are different. When we talk about ductal carcinoma, the word ductal is a phenotype. It is a type of the cells. So these are cells with, they show pseudostratification. The nuclei of acinar carcinoma are round. The nuclei of ductal carcinoma, and they used to be called endometrioid carcinomas of the prostate. So they are like endometrial carcinoma. They are oval nuclei, pseudostratified. So that's a different appearance. While in intraductal carcinoma, the word ductal refers to its location. So this is within the ducts. Now, intraductal carcinoma, now this is where again, it becomes a little bit confusing with the words, that the intraductal carcinoma can be either of acinar type or ductal type. So you can get an acinar carcinoma, which is going back into the ducts. That is the intraductal carcinoma of acinar type, or you can get ductal carcinoma, which is growing back into the ducts. So that will be intraductal carcinoma of ductal type. It doesn't matter. This ductal versus acinar, I think it's quite likely in future WHO classifications, this might even disappear. There are lot of expert uropathologists who believe that this distinction between ductal and acinar is entirely artificial, and these are all really the same tumor types with different morphological appearances. Do you grade? Its life has become a lot simpler now. You grade by morphology. So if you've got something that looks cribriform, or it looks papillary or cribriform, then you grade it as higher grade. So it would be pattern 3 or it would be pattern 4 if it's got necrosis, pattern 5. But if you got what looks like the phenotype of ductal type adenocarcinoma, but the glands are all separate, so the architecture is like Gleason pattern 3, then you call it Gleason pattern 3. So that's what is called pin-like ductal carcinoma, which we now would call pin-like carcinoma. Okay.
Yeah. Thanks very much. And just one more comment.
Yeah.
Go ahead.
Sorry, Santosh.
Yeah, I just wanted to make a comment with Verma sir. You're very correct in saying that the communication is the key. And maybe in UK, I don't know, but at least in our country, we get very high-grade cancers, metastatic cancers and all. And we get higher end of the spectrum. So 4 and 5, they get more confusing. So rather than 3 and 4, the problem comes with 4 and 5, which is we always should take into consideration the PSA values and the presentation of those. So that's also important. But I totally agree with you that when we write a report and on the borderline cases, it's important to put the exact communication on the reports actually.
Correct, Santosh. So yeah, I think it is. You're right that when it comes to patient management, they have to consider the. I mean, we are only one cog in the wheel.
And I also
so they've got the MRI findings, they've got the PSA findings, they've got the DRE findings, they've got the bone scan findings. So sometimes you got cases where you are worrying about whether it is Gleason pattern 4 or 5 or whatever stuff, and the patient's got bone mets.
Bone mets, yes, sir.
Right, and it's irrelevant. The whole thing becomes irrelevant then, isn't it? So again, you're absolutely right. But at the same time, when you're reporting it, it has to be based on what you're seeing under the microscope. It is the clinician's job then to, because otherwise there's a risk of double counting. So where you upgrade it based on the PSA or whatever else, and they don't know that you have upgraded it. So you had a borderline case between 4 and 5. You called it 5 because the PSA was very high. And they say, now we've got a pattern 5 with a high PSA. Right. So I would recommend to leave the PSA, etc. is for them to factor in. I would grade by what you see under the microscope. But again, as I keep saying, the sampling error is huge.
Huge.
So whatever you're doing is you're just giving a rough estimate of what is there in the patient. You can be very, very precise about what is there in the biopsy, but you can never be precise about what is there in the patient. And what is in the patient is all that matters. What is in the biopsy is academic, isn't it?
Just one more point. I don't know whether in the UK, but we are not doing the continuous foci versus discontinuous foci of cancer. I don't know whether in UK it is part of the report. So there is a Gleason 3, 4, but it is for 20% discontinuous, 20% continuous.
Yes, so that would be about tumor extent.
Whether it's a continuous foci or skipping focus within the course. I think that's very, very complicated. So I totally agree that prostate has been made very complicated actually.
Correct. I think it's very complicated when it's actually very simple. Right. So this is where, again, this is another example where we have made it complicated. It doesn't have to be complicated. So now we are totally moving track. Okay. We're not talking about grading. We are talking about tumor extent. So the problem you have is, now I'm going to show this with my finger. Okay. So if I've got a core of a 20 millimeter core with 1 millimeter tumor at this end and 1 millimeter tumor at that end. So is that the tumor extent, is it 1 millimeter or 2 millimeter by adding up the two? So 2 foci are 1 millimeter each, or is it 20 millimeter? So which is the right one? It depends, because if that is the real tumor and you got a biopsy which has gone that way, then what are you reporting? So what you're saying is that this is the minimum extent of the tumor. So when I report it as 7 millimeter on my biopsy, what I'm saying is that the minimum diameter of the tumor is 7 millimeter. It may be 7 centimeter for all I know, but it can't be less than 7 millimeter, whatever I'm reporting it as. Right? So what we are reporting is a minimum. So if I've got a tumor like this and I've got a discontinuous focus, so then both I would add these two and say that is 15 millimeter within brackets discontinuous. Okay. But we have a problem. The problem is when I see my biopsy, I don't know whether that may not be there at all. And these might actually be two separate foci of tumor.
Yes, sir.
In which case the patient doesn't have a 20 millimeter tumor.
Yes.
So this might be two separate 1 millimeter tumor. And there is no way for the pathologist to know while looking at the biopsy. So what do I do in practice? Two things. One is consider the morphology. So if I've got two bits of tumor which are a little bit further apart, but they look identical, maybe they're both gland, right? Then I would consider that as one. I would not bother with discontinuity. I would, on the other hand, I would, the whole aim of again, I come back to the same thing. It is not about precision. It is about communication.
Yeah.
So what you got here is, if I've got these two ends, so I've got a 14 millimeter core with 1 millimeter tumor at each end. The way I would report it, I would report that as, say, 14 millimeter within brackets discontinuous. Now, on another core, if I've got 15 millimeter continuous tumor, then I don't bother. That is the end of my, so it will say 14 millimeter discontinuous, and on another core, it will say 15 millimeter. So the maximum tumor length is still 15 millimeter. But if all the other cores have got less than 14 millimeter discontinuous, less than 14 millimeter, then at the bottom line, I would write a line saying, so I'd have 14 meter discontinuous, but the maximum in continuous tumor length is 3 millimeter or whatever it is.
Okay.
So then the clinician knows, now does he have a minimum 3 millimeter and multifocal, or does he have a 14 millimeter? I don't know. Nobody knows.
Nobody knows.
It's not possible to know.
Yeah.
Most of the time, it doesn't matter.
Yes.
So this again, we worry about all this tumor extent, but the sampling error of the biopsy is huge. So when you're looking, we are essentially blind men and the elephant, isn't it? It happens whether we are feeling the trunk or the leg of the elephant, and we then make up a whole story about the size of the elephant. Right, so that's essentially what we're doing with these biopsies. So you are trying to give an estimate. Now, Santosh, I know are you okay with this? I know we have gone sideways. Okay, we've gone tangentially. We are no longer talking about this in grading. Yeah, so if you're okay to talk about this, then we'll continue on this. Right, because these are important things in practice. So if you've got a digital biopsy, or say, you've got targeted biopsy. So they have seen a 3 centimeter, 30 millimeter tumor on MRI, and they have targeted it. Does the size of my tumor matter? The tumor size in my biopsy, does it matter? So whether I call this 7 millimeter or 10 millimeter or 14 millimeter, they are going to treat him as a 30 millimeter tumor, because they can see a 30 millimeter tumor on the MRI. Yeah. So they don't care. But it does matter where the size of the tumor in a targeted biopsy matters, paradoxically, if there's very little.
Yes. Yeah.
If I've got a 1 millimeter tumor in a targeted one, then I have to mention that 1 millimeter is important, because that might be incidental. So that 3 centimeter lesion that they're seeing on MRI might be some benign process, or it might be a urothelial carcinoma, or it could be anything. They have not sampled that, and they've just picked up an incidental less than 1 millimeter 3+3. So there the size becomes important. So actually, in a targeted biopsy or a digital biopsy, which is done for extensive prostate cancer, the size doesn't matter. The length of the tumor size doesn't matter unless it is very small. If it is very small, you need to mention that it's very small, and mention that there is a possibility that this is not representative of the radiological or DRE findings. Yeah. So again, and that correlation, that again, is communication.
Yeah, agree, sir.
Yeah. I'm sorry, I think you probably heard the word communication about 1 million times today, but I think it's that important.
Yes, sir.
So, Paramita,
do you have a question? Yeah.
Yes, sir. If I remember correctly, sir, you do core-wise grading, and you do a global score, recent score for the patient.
Nadeem, Paramita, can I interrupt? I'll tell you why I say this. Are we okay for time? If so, I have a few slides on that. It's easier for me to demonstrate it on the slides. Are we okay for time? But that will take me a few minutes.
Perfectly fine. Please go ahead.
Okay, if you're okay with time, then Paramita, then let me go through that, because I know exactly what you're asking me, and I've got, like in many other things.
I want to know, I understand the importance, but I want to know whether your clinicians look at that, because we in India are kind of bound to follow the CAP protocol, because most cases follow it. Our clinicians are aware of the CAP protocol. So that is tedious in itself, and it makes our prostate reports long and it takes a lot of time. So adding the global score to it, if our clinician is not going to look at it, the question is, should we do that, or
okay?
How?
So this is your question, right? Can you see my screen?
Yes, sir.
Can you see my screen?
Yeah. Yes, we can.
So this is a situation you're talking about, is it? When you get in different cores. So the blue is pattern 3, the red is pattern 4. So there you got one core which shows 3+3, another core 3+4. Now, if you take it as global, you take all of this is from one single tumor, it would be 3 plus 4 equals 7. But if you grade it separately and then you go by the worst, then that would be 4 plus 4 equals 8. Paramita, that's the scenario we are talking about, right? Yeah, perfect. So what did ISUP do? ISUP said that you should report the grade of the individual positive core or container. That is mandatory. Now that's fine. So the reason for that is, if I've got this here, it's very likely that this is from a separate tumor, right? So the idea, so these grades don't matter. So you are recording this if you want to record it, whatever, but they are going to treat by this one here because that's the one that's going to drive the prognosis of the patient. The problem is you have this scenario where you got the same thing, but you got a tiny bit of, one core has a little bit of only pattern 4. So here again, the global score would be 3 plus 4. The worst score would be 4 plus 4. And in this situation, the worst will overgrade because this is very likely to be just the core happened to hit only the pattern 4, to sample only the pattern 4. So in this case, if you do this method, it will overgrade. And as I said earlier, so if you look at what they showed was that most of the upgrading that happened with ISUP was due to this rule about giving separate scores for each core. So which one would you report? So should you report, so in this situation, the worst score is appropriate. In this situation, the global score is appropriate. How do you, so which one should you report? So we did basically, you can pass the buck essentially by reporting all the scores and let the clinician choose, which is what is commonly done in the US, where you would simply report everything. They would not even report a global score. They would simply give all these numbers and let the clinician choose how to treat the patient. So which score would the clinician use? So if you have this situation, so we did a survey on this. We did a survey of urologists and oncologists and asked them, we presented them with this sort of a scenario and asked them, how would you treat the patient? Because that's eventually what matters. And as you would expect, you had 1 millimeter, 4 plus 4 equals 8. And about 80% of the clinicians said they would treat this patient as a 4 plus 4 equals 8. And that is almost certainly not correct, because this is very likely to be undersampled part of the same tumor that is there in the other cores. So as I said, the issue here is a communication gap. So we published an editorial in which we said the Gleason score assignment is the sole responsibility of the pathologist and not the clinician. The clinician cannot decide which Gleason score to use because he hasn't seen the slides. It is your responsibility as the doctor who has actually seen the histology to decide which is the right Gleason score for this patient, not the clinician's job. The clinician cannot. He hasn't looked at under the microscope. The pathologist is best placed to identify the most appropriate score for an individual patient. And the best score may be the global score, or it may be the worst score based on the pathologist's judgment of the case. So not the clinician does not decide, it's a pathologist. And you may have to consider the morphology. So again, it is kind of interesting as pathologists. We just talked about the, continuous, discontinuous. We kind of ignore the morphology altogether and make rules that I have to report the global or I report the worst. No. So if I take this case here, so here I've got the blue is pattern 3, the red is polyform pattern 4, and the green is cribriform pattern 4. So in this case, you've got pattern 3 and polyform pattern 4. So this one here is morphologically similar to that. It's very likely that all of this is from a single tumor. So personally, in my experience, I would simply report this as Gleason score 3 plus 4 equals 7. Next case. But what about this situation, where I've got a similar one, but
not progressing.
Yeah. Okay. Is it
they have
progressing
moved.
at all?
Yeah, they have moved.
They moved. Okay.
They have moved.
So,
they have moved.
Yeah. Okay. I think there may be sometimes this is the joys of the internet, isn't it? Sometimes there is a lag.
Yes, probably.
Right? You got it now. So this is the same situation as the previous one, except the 4 plus 4 is entirely cribriform. While all this, in the other cores, the pattern 4 was polyform glands. So this is very likely to come from a separate tumor. Now, is that a 4+4 tumor? As I showed you with the, because of the sampling error, it's quite likely that this tumor also has pattern 3 somewhere else, which has not been sampled. So this is not a perfect science. It's only an estimation. But this tumor is very likely to be different. Probability-wise, is likely to be different. So in this case, this patient should be treated like a 2 millimeter 4+4 rather than a large 3+4, right? Because this is likely to be a separate tumor. So in this case, the bottom line would be 4+4 equals 8. So essentially, what I argued is that there is no substitute for judgment. The pathologist, you cannot have a one-size-fits-all. You talk about personalized medicine. You use your judgment. You decide in your judgment whether this is all from one tumor or whether it is from multiple tumors. And pathologists already use their judgment to make critical decisions such as the diagnosis of cancer, whether it is Gleason pattern 3, Gleason pattern 4, or Gleason pattern 5. So if we say that it is okay for pathologists to use their judgment for those, surely we can let them use their judgment to decide whether this is one tumor or multiple tumors and which is the best Gleason score for that patient. So essentially what I argued was that pathologists should be encouraged to use judgment to decide which Gleason score is best for an individual case. So ISOP recommendations is that the individual core or container Gleason score is mandatory and the case level Gleason score is optional. So we argued in both the histopathology editorial and in the other AJSP paper that the case level should be mandatory. So you have to put what you think is the best Gleason score for that patient. If you want to give millions of other Gleason scores, it's a waste of time, but you can do that. That doesn't matter one way or the other. But the score that is used to treat the patient should be your decision. So that's essentially what we do and what we argued.
Thank you, Dr. Varma. I think we'll need to.
Yeah, I think it's pretty long
now. Yeah.
Yeah.
Thank you very much indeed.
Yeah.
That was
brilliant. I think you got my email address. So if anybody's got any questions and if they want to email me, feel free.
Thank you, Murli.
If not,
for that
it's
very nice conceptual talk, and thanks a lot. It was really enjoyable.
I hope so.
Thank you, sir. Thank you so much.
All the very best.